So here we are.
Thank you very much.
Thank you very much for your kind invitation, Mr. Chairman. So, you know that up to 20% of the patients who are assessed in our department, vascular department, are finally declared non-candidates for revascularization. And for these sort of patients, venous arterialization has proven to be an effective treatment for increasing the limb salvage rate in ranges from 60 to 70% in different series of cases. If we talk about percutaneous venous arterialization, there are basically two strategies. The proximal arterialization, described by Stephen Kuhn with the limb flow device, and a variant described, the Piper technique, described by Bruno Migliara, who uses a pioneer ultrasound catheter to connect the artery and the vein. If we talk about distal arterialization, Roberto Gandini described a homemade method in which he uses the anatomical disposition of the plantar veins at both sides of the artery, and what he basically does is to face an angle catheter to the arterial wall, to the calcification, and then breaks into the vein using a CTO wire. And finally, based on the Ganside approach, our group described the venous arterialization simplified technique, the VAS, which was published last year in the Journal of Endovascular Therapy. But the fact is that it has not been clarified yet whether it's better to perform a proximal or a distal DVA, since the results, the outcomes of the different studies are quite equivalent in both locations. So we thought that it would be ideal to join the best of both worlds, trying to offer our patients the best treatment for every specific scenario, and that's why we decided to test if it was feasible to perform a sort of lymph flow-like proximal DVA using the VAS technique.
The technique is demonstrated in a 65-year-old male with a non-healing first toe amputation and a prior failed PT recanalization attempt due to an early arterial recoiling. The baseline angio showed an occlusion of the 3 BTK vessels with extreme calcification. And complete absence of a distal target vessel at the level of the foot. Ultrasound-guided access using a 21-gauge needle is achieved at the level of one of the double plantar veins, and a 018 wire is retrogradedly progressed in a proximal direction. Then a 4 French sheath is inserted. The 018 wire is advanced up to the origin of the posterior tibial vein. A simultaneous Flebo angiogram is performed to find out which is the best spot to perform the AV communication. Then a 5mm gooseneck snare from Medtronic is advanced through the distal venous sheath, and a second snare is introduced from the femoral arterial axis up to and parallel with the venous snare. Once both elements are aligned and using the best projection to view them overlapping, a 21-gauge needle is inserted percutaneously, pointing to the center of the snare loops and passing through them. Then an 014 Advantage Terumo wire is introduced through the needle. The needle is retrieved, and the venous snare closed and retrieved so that the wire is grasped and externalized through the venous axis. The arterial snare is also closed and retrieved, establishing a through-and-through wire from the artery to the vein. The AV communication is secured by a 3.5mm balloon angioplasty. A 3.5 by 26mm papyrus balloon expandable covered stent from Biotronic is deployed at the level of the AV anastomosis. Subsequently, the venous segment of the stent is flared with a 5 mm angioplasty balloon. In order to gain room for the venous covered stent, all the track of the PT vein is dilated with a 5 mm balloon. Thereafter, two 5x20 Viaband stent grafts are deployed to destroy the valves and avoid bleeding off venous flow via collaterals. By looping the tip of the glide wire, we gentle cross the remaining valves of the foot, gaining access to the venous plantar arch. A 4 mm balloon angioplasty of the plantar vein is performed. In case of residual valve stenosis in the completion angio, valve destruction is performed using a 3.5 mm cutting balloon from Boston Scientific. This is the completion angio with a patent stent graft. And an excellent flow into the venous plantar arch.
So what are the advantages of the VAS technique compared with the other ones? Well, basically the universal availability and the low cost compared with the lymph flow device and the people technique. This is no longer a blind technique, and this overcomes the 20% failure rate of Gandini's maneuver. The technical demand of the maneuver is fairly low if you have a minimal experience in retrograde puncture of distal vessels. And when you're dealing with calcified vessels, you have a really improved needle penetration power compared with a lymph flow device or the Piper's technique. And as you have seen, with the VAS technique, you can either perform a distal DVA or a proximal lymph flow-like DVA using off-the-shelf devices. One can argue that this is a less codified technique compared with a lymph flow device, and I really accept that, and that there's still very few data with regards to reproducibility, although we have amazing feedback from different centers from Spain, United States, Portugal, Japan, or Ukraine. And you can reach to the comments of these centers in our LinkedIn account. Finally, we'd like to stress the importance of not using venous arterialization unless you are really dealing with no option CLI, and I neither will perform DVA in the case of sepsis, extensive necrotic tissue or infection, a prior DVT, or allergy or intolerance to antiplatelet therapy or anticoagulation. Thank you very much for your attention.